Uh, Today, I'm Dr. Chris Galadima, a consultant ophthalmologist at the National Eye Centre Kaduna. This morning, we'll be discussing dry eye disease and its management. We all know that dry eye disease is a very important disease, causing a lot of discomfort and difficulties for people who suffer from it, and it's a common disease that presents at the clinic. The outline of the presentation is as is seen here on the screen. I intend to do an introduction and then we look back at the tear film, its source, its structure, composition, and function. Then we'll look at dry eye disease properly, then also its management and conclude. The tear film is classically described as a thin trilaminar fluid structure that lines and lubricates the ocular surface. So it's a structure in front of the eye. The ocular surface is made up of the squamous stratified epithelium of the cornea, the stratified columnar and columnar limbal epithelial cells, the cuboidal epithelial conjunctival epithelial cells with goblet cells, and then the cuboidal orbital conjunctival epithelial cells with goblet cells. Also the stratified columnar fornix epithelium with goblet cells, and then the epithelial cells also lining the tarsus, and up to the mucocutaneous junction, that is the ocular surface. This slide shows a picture of the eye, the front part of the eye and the lids. It shows the source of the tear film. The lipid layer, which is the anteriormost layer, is secreted by the meibomian glands that are located within the tarsal plates of the lid, while the aqueous layer, which is forms the bulk of the tear film, is secreted by the main lacrimal gland and accessory lacrimal glands within the conjunctiva. The third layer, the mucoid layer, which is made up of mucin, is secreted by the goblet cells that are located within the conjunctival epithelium. So these are the various sources where the tear film is sourced. This is also a schematic that shows us the outer lipid layer, the middle aqueous layer, and the inner mucin layer within the eye. The inner mucin layer, the outer lipid layer prevents evaporation of the tear film of the tears, while the middle aqueous layer, in which most, is the layer where most of the molecular constituents and cellular debris are located within the tear film. The inner mucin layer, which is, it causes absorption of the tear film to the epithelium. This is another schematic formation of, format of the normal tear film. It shows also the outer oily layer, then the aqueous layer, and the mucin layer. But it also displays some of the molecular constituents of the tear film, electrolytes like sodium, potassium, chloride, and calcium, then proteins, lysozyme, lactoferrin, lipocalin, and albumin. It also has, the aqueous layer also contains the cytokines. So these are some of the tear composition from the lacrimal gland, mainly the water, then the ions, sodium, potassium, calcium, magnesium, phosphate, and sulfate. It also has secretory proteins like immunoglobulin A, secretory proteins from granules, lactoferrin, and peroxidase. These are some of the constituents of the tear film from the lacrimal gland. While from the ocular surface, you have normal cell debris from natural cell exfoliation, extra cell debris from stress, allergic, or cytotoxic insult. Then we also have the mucus-like macromolecules from cells. then metabolites and proteins mediators and mediators from the nearby vasculature. There are also inflammatory mediators from mast cells and white cells as well. So the main function of the tear film is to protect the eye from drying, maintain the smooth refractive surface of the cornea, defend against eye infections, allow gas to pass between the air and the avascular cornea. It also nourishes the cornea and supports corneal hydration due to its relative hyperosmolarity. The tear film, the concept of the tear film has been upgraded into the concept of the tear film functional unit, where the ocular surface, that is the cornea, conjunctiva, meibomian gland, and the main accessory lacrimal gland, the neural networks that connects them, act together as a functional unit, including also the endocrine system, and then also the centers within the midbrain. They all act as a functional unit. This was popularized by Billman in 2006. Now, this schematic shows the neural connections of the lacrimal functional unit and the midbrain. There is the afferent portion is the one in yellow, while the efferent from the superior salivary neurons nucleus is the one in blue. So when it is formed, this picture shows the drainage of the tear film once it is formed by from its sources. It flows in the direction of as shown in the diagram, the arrows flowing from the lacrimal gland into the conjunctiva superior fornix, and medially on the conjunctiva and cornea to the lacus lacrimalis, then ultimately into the puncta, where it is drained into the canaliculi, lacrimal sac, and nasolacrimal duct, which opens into the nose at the inferior, under the inferior meatus. This further shows the drainage of the tear film through the canaliculi into the lacrimal sac and eventually into the nose. Now, what is dry film? There are so many definitions that has been given, but the dry eye workshop study of 2007 defines dry eye disease as a multifactorial disease of the tears and ocular surface that result in symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. It is accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. Now, this is the most commonly quoted definition of dry eye disease. It is popular because it tends to highlight the important things that has to do with dry eye disease. The tears, the ocular surface, and the potential of ocular damage to the ocular surface. It also highlights the fact that there is increased osmolarity of the tear film and inflammation during or in dry eye disease. This slide shows us some of the pathophysiology or pathogenesis of dry eye. Once there is a dysfunction of secretion or a reduction in secretion of tears from, say, the lacrimal gland, there is altered composition of the tear film, and leads to increased osmolarity of the tear film. So this hyperosmolarity and decreased amount of tears leads to tear film instability. So hyperosmolarity and tear film instability are the main issues or the main problems, that occur during dry eye. And the hyperosmolarity also leads to inflammation of the ocular surface. So those are the events that leads to ocular disease and ocular discomfort and chronic pain in dry eye disease. This classification also is from the DEW study. It is the most popular classification. There are other classifications. It classifies dry eye into mainly two broad groups, the aqueous deficient and the evaporative. The aqueous deficient also is classified into the Sjogren syndrome dry eye and the non-Sjogren syndrome dry eye. The Sjogren syndrome also is subdivided into the primary and secondary, while that of the non-Sjogren it can be caused by lacrimal deficiency, lacrimal gland destruction, graft host disease, reflex block, and drugs. On the evaporative side, it occurs usually following lid diseases and ocular surface disease, such as in meibomian gland dysfunction, vitamin A deficiency, poor lid congruity, topical drug preservatives, low blink rate, and contact lens wear. This is a long list of symptoms that commonly occur in dry eye. You have dry sensation, burning sensation, stinging sensation, irritation, tearing, foreign body sensation, gritty sensation, photophobia, redness, and increased blinking frequency. Some of the signs that are also seen include the loss of corneal luster or gleam, the dry appearance of the cornea, reduced marginal tear strip height, usually less than 1 millimeter, and then supravital staining patterns that may be shown from the use of vital stains like fluorescein, lissamine green, and rose bengal. Then there may also be signs of underlying disease. These are some of the tests that can be used in assessment of the tear film structure. There are so many. This list is not exhaustive. It includes tear breakup time, fluorescein staining, rose bengal and lissamine green staining, as I've mentioned, the Sharma's test, the phenol red test, the tear lysozyme assay, tear lactoferrin assay, and conjunctival scraping. It also includes conjunctival impression cytology, tear pH measurement, tear evaporation rate, tear fan test, fluorophotometry, tear osmolarity, tear scope, and mammography. Now, you notice that these tests are so many that in a usual clinic setup, you cannot do all these things. So there is a practical workup. In a practical workup, Nichols has suggested that the following tests should be done. Symptom questionnaire. The symptom questionnaires are more like a screening test once somebody is suspected to have tear eye disease. And there are different types of questionnaire. We have the OSD, that is the Ocular Surface Disease Index questionnaire, and then the dry eye question, 5 dry eye questionnaire. This is how this questionnaire look like, the DEQ5 and the OSD-I. They generally ask questions, about the symptoms that the patient has with the intention of quantifying them, so it can be used to not only diagnose dry eye disease, but it can also be used to quantify or measure the severity of the disease. Then there's also the need to do the clinical history and examination of a patient with dry eye. One should not just concentrate on the surface of the eye, but to do a thorough examination of all structures of the eye and of the body. Then the TF film breakup time. It is a simple test, usually using fluorescein. When you apply fluorescein, you ask the patient to close his eye or blink, and then when the eye opens, you now read out, watch for appearance of dry spot on the cornea, and then measure the time it takes to appear. Usually, in normal it is above 10 seconds, but if it's less than 10 seconds, it indicates presence of dry eye. Then cornea staining with fluorescein. This is to observe the pattern of staining. In some cases, you may see punctate epitheliopathy, or the fact that some areas are not taking up or are not holding the stain properly. Other, vital stains can be used also, like rose bengal. With rose bengal, it is the devitalized epithelial cells that are stained, and once you apply rose bengal and see staining, it means some cells are dying due to the presence of dry eye. Lissamine green can also be used. It stains the ocular surface, either the conjunctiva or the cornea, when the mucin layer is not present, so it will stain the epithelium. The Schirmer test can also be done. In the Schirmer's test, we use the Wattmann's number 41 filter paper, which has the dimensions of 5 millimeters by 35 millimeters. We bend it and hook it over the junction between the lateral 1/3 and the medial 2/3 of the lower lid, and then measure after 5 minutes. Normally, it should stain between 5 and 35 millimeters of the fluorescein. Less than that will indicate dry eye. While doing this test, it is also important to do an examination of the lid margins. Sometimes the affectation of the lid margins and the tarsal plates within them can cause dry eye. So it's always important to examine the lid margin. And also to look out for the presence of anterior blepharitis or any signs of inflammation by examining the lashes properly to see if there are some scales, or dandruff-like material there, or dry material around the lashes. Then at the end, one should also try to express the meibomian gland that is within the lower lids by applying pressure with the index finger and observing if whether or not lipid material is coming out through the openings of the meibomian glands at the lid margin. There are some use index finger, but there are some equipment that can be used that are made specifically for depressing the meibomian glands. So this test constitutes the basic minimum that one should do for a patient with suspected dry eye. For treatment, there are several treatment modalities or options that are available in treating dry eye, and there is no one that is a magic bullet for all type of dry eye, but one has to choose depending on the suspected cause of the dry eye and the severity of the dry eye. The treatment goals include the relief of symptoms, the enhancement of lubrication, stabilizing of the tear film. We also aim at protecting the ocular surface and then retard or evaporation. Also to reduce or suppress the inflammation that is associated with dry eye on the ocular surface and to support meibomian gland function, and then also to maintain adequate secretion. So, as I have said, there are many options for treating dry eyes. The use of artificial tears substitute is usually the first line of action in most types of dry eye, but others include the use of gels and ointments, moist chamber spectacles. There anti-inflammatory agents can also be used, like the topical cyclosporin A, which has been prepared and has been approved for use in dry eye in the form of Restasis. And then corticosteroids can also be employed to bring down the inflammation associated with dry eye. Omega-3 fatty acids have also been found, to improve the symptoms associated with dry eye disease. Tetracycline can also be used. It has anti-inflammatory effect as well. And then punctal plugs can also be used, to plug the puncta and reduce drainage of the eye, and therefore increasing the amount of tears within or over the conjunctiva and cornea. Then secretagogues, these are drugs that stimulate the production of tears, such as pilocarpine. Topical pilocarpine is known to improve dry eye, and also the oral pilocarpine can also be used in severe cases. Autologous serum can also be used for treatment of dry eye. Contact lenses may have a place in some cases of dry eye, especially when there is damage to the ocular surface. If you have punctate epithelial erosions that are not healing, you can now apply contact lenses, but it is better to use the contact lenses that have low water holding capacity rather than those that have high water retaining capacity. Because in those that have high water retaining capacity, the use of contact lens may actually worsen the dry eye condition. Surgical procedures like use of amniotic membrane, lead surgery, tarsography may also be used in some cases of dry eye. There are also surgical procedures like the salivary glands transplantation, but it's not, this type of procedure is rarely done now. So thank you very much. In conclusion, I want to say dry eye disease is a very common is very common and causes significant suffering among adults. It is potentially a blinding condition and therefore an important clinical entity. Thank you very much. We will now have time to look at questions that participants might have asked. No questions so far. No questions. Okay. In that case, we'll end the presentation.
I have a question, sir. I was trying to type it before. Let me ask it. Thank you for the presentation. As you mentioned Sjogren's syndrome as a cause of dry eye. So in the clinical evaluation, what exactly do we look out for in order to rule that in or out?
Oh, okay. Sjogren's syndrome maybe associated or usually associated with dryness of other mucous membrane, not just on the conjunctiva or cornea, not just the eye. So one should look out for dryness of the mouth and other mucosal surfaces, and to also palpate the salivary gland to find out whether it may be affected, either swollen or it may be tender, because it's an autoimmune process that has inflammatory component to it. So a check on the salivary gland might, if it is found to be tender or swollen, it is supportive of the presence of Sjogren's syndrome. You got that?
Yes, I did. Thank you. Please, as a follow-up to that, the salivary gland transplantation, which particular salivary gland is suitable for getting the tissue for transplant?
Several techniques have been described, but it's the the submandibular salivary gland, migrating it its duct up to the conjunctiva area. It's a very complex and extensive surgery, and these days it is rarely performed.
Thank you.
You're welcome.
I think there's one question in the Q&A box.
Okay.
Should I read it out?
Read it out. I'm not able to open it here.
Okay, let me read it out. Somebody asked that, how can we differentiate the possible causes of dry eye clinically? That's the first question. Then the second one is, what is the role of serum in the management of dry eye as per the mechanism of action of serum in managing dry eye?
I see the questions now. Thank you. The first question, to differentiate between the possible causes, is one has to not just concentrate on the surface of the eye, but also on the adnexal structures. If we are able to examine the leads properly, and we find the presence of either inflammation, or if we do meibomiography and we see drop out of the meibomian glands, it will be indicative of the evaporative types, because the oily layer would have been disrupted in that. But if the leads are normal, but the patient still has dry eye, then it is more likely to be of the aqueous deficiency type. But like I said, the examination should be thorough and should include all structures of the eye and of the body. We mentioned the checking of the salivary glands in case there is swelling or inflammation there, which would be suggestive of Sjogren's syndrome. Then, of course, in your history, if the patient might present with issue of dryness when he sits probably in his room that is air conditioned, we know that this might not be something related to structural issues within the eye, but the environmental factors causing dry eye. The next question says, please, what is the role of serum in management of dry eye? Yes, autologous serum is found to be useful in managing dry eye, especially in patients that you've tried all the tear substitute and gels and all that, and you have not found much improvement, autologous serum might be an option to look at. We have another question from Bulus Dodo. Thanks, sir. What is the difference between dry eye syndrome and allergic conjunctivitis? Okay, it is very common to confuse the two because of their symptomatology. They tend to look, present with this similar conditions. But one thing you should be watchful or careful about is that while allergic conjunctivitis, itching is a predominant symptom. In dry eye disease, itching is not usually the predominant symptom. It is the dryness and grittiness or that sensation of dryness in the eye that is the main predominant symptom. So if you check the predominant symptoms very well, it will help you to begin to differentiate what is really presenting to you. But beyond that, you could also look at the surface of the eye or the conjunctiva. While you are looking in allergic conjunctivitis, you'll be having things like papillae and conjunctival injection in the tarsus. In allergic conjunctivitis, in the dry eye disease, that's not what you see. You tend to see dryness and mild conjunctival injection. I think this if you are able to be careful with your symptoms and physical signs, you'll be able to differentiate allergic conjunctivitis from dry eye syndrome. A lot of the patients that come with dry eye syndrome in our clinics tend to be easily written off as allergic conjunctivitis and cause them to keep coming back for treatment. Okay, we have another question. How does tetracycline help in the management of dry eye? Okay, thank you very much. Tetracycline has anti-inflammatory effects, and it is and you know that ocular surface inflammation is an important aspect of dry eye disease. So tetracycline helps in reducing the inflammation. It is also thought to be secreted in the mucus that is secreted by the meibomian glands and helps to make it less viscid. And apart from that, if there is inflammation, infection in the lids, blepharitis, it will help in controlling the infection if there is any. Okay. The next question is, can you explain how tear film breakup time is done in the clinic? It is a very simple test. All you need to do is apply fluorescein into the eye, then ask the patient to close his eye for about a few seconds, and then ask the patient to open the eye or blink. Once you've opened the eye, you start counting the seconds while watching the surface of the cornea for the appearance of the first sign of dryness or where the fluorescein film breaks up. You will see a dark spot appearing. Once you see that dark spot, you now stop counting, and that's noting the time. You know the time where it appears, and then that is the amount of time that you measure. For instance, if it takes 12 seconds, the tear breakup time is 12 seconds. So if it is usually in the normals, it is above 10 seconds. If it is less than 10 seconds, if as soon as you put it within 5 seconds, or the tear breakup time is 5 seconds, you know that person has dry eye. So it's a very simple test. While doing your what do you call it, applanation tonometry, before that you can even do the tear breakup time before you do your applanation tonometry, and it does not take long, just a few seconds, 20 at most, you know. So that is how it is done in the clinic. Okay, I think we've taken all the questions.
So thank you very much, Dr. Galadima. That was a very enlightening lecture, because really, like you said, dry eye syndrome is something we underdiagnose because we write them off as allergic conjunctivitis. And I think that explains why we keep on getting these patients coming back again and again and again, because they are not getting relief with the treatment for allergic conjunctivitis, since that is really not we're applying the wrong treatment for the wrong disease. So sharpen our eyes now in our clinics for these patients and refer them appropriately to where they can get the correct treatment. So thank you all for coming, and we'll see you next week by God's grace.
Thank you.